Ladies and gentlemen, welcome to the most thrilling LinkedIn Live that you're going to see today. And that's not just because this may be the only LinkedIn Live that you see today. My name is Stephanie Dorwart, and I'm the CEO and owner of Altius Healthcare Consulting Group. Altius transforms the financial and operational performance of hospitals through productivity, workforce engagement, and leadership development. Today, we are diving headfirst into the exhilarating world of healthcare standardization and administration. I hope that you've all have your spreadsheets available and you're ready to roll. If you thought productivity was not fun, you've never worked with Altius. So, two of the topics we're going to really cover in detail today include standardization and administrative positions. And they are both extremely important to productivity and workforce optimization. So if you're joining us live, or even if you're watching the replay, please drop your comments regarding standardization in healthcare, as well as administrative positions, in the comments in the chat, and we'd love to answer your questions live or after the show. Standardization in hospitals and healthcare systems has never been more important than it is today. And it really refers to the establishment of policies and procedures that provide consistent and systematic references to different types of work that we do. It may be workload rules, it might be positions, it could be clinical processes or procedures. There are a lot of different areas where we can actually improve our workflow through standardization. So today we're going to dive into all these areas a little bit, just touch upon the surface of them. And please, if you have anything to share, I'd love to hear from you in the comments. The first type of standardization that hospitals and healthcare systems could really benefit from is clinical procedures. And this regards your procedures in all of the areas. It might be a uniform clinical protocols. It could be guidelines for patient diagnosis. It could be standardization of treatments and follow-up care. Within the electronic healthcare records, there are a lot of opportunities for us to standardize the process of care and ensure that different providers, different organizations, different hospitals, different departments are following the same protocols. And when we standardize these procedures of care, not only are we improving processes and efficiency, we're providing better quality of care and better systematic review of our patient diagnosis and our patients. And when we do all of those things, systems are going to improve. The next area where there's opportunity are work roles. And work roles really deal with the clearly defined roles and opportunities and responsibilities for healthcare that everyone knows and everyone is aware of what their tasks are and how they impact the overall department that they're working within. In a lot of organizations, these work roles are not defined. Many times when I'm working with clients or Altius is working with clients, we might hear someone say, wow, that person, they are really productive. And, if we lose them, we're probably going to have to replace them with more than one person. In fact, we may need to account for that in future because they're retiring, and we might need 2 or 3 people. And the worst part about this is we often hear that if they get hit by a bus, and people do say this, we're going to have no idea what to do. And that's really where work roles and work systemization comes into play. By documenting everyone's work roles as well as what their flows are and understanding their standard work, you are in a much better position to scale your resources and to duplicate those processes. So making sure that you have clearly defined roles and responsibilities in all of your departments in all areas is paramount. The next area is training and orientation. Many times we have different training processes and different orientation processes for different areas throughout the hospital or throughout the healthcare organization. And this leads to a lack of consistency on how we approach the onboarding process. It's important for us to really understand how we're going to onboard new employees, how we're going to orient our clinical roles and our clinical leaders, how we're going to orient our clinical bedside nurses, how we're going to orient our frontline staff. How do we bring everyone on board? So making sure that there's a standardized training program that deals with the mission, vision, and values of the organization, as well as all the policies and procedures that we need to know, as well as areas like human resources. How do you request jobs? How do you conduct your performance evaluation? How do you function in all these areas? And making sure that you have standardized protocols for all of these areas. This helps you have a competent workforce, and it is extremely important in recruitment and retention. The next area we want to talk about are volumetrics. If you're watching this today, there's a reasonable chance that you're either interested in productivity or you already have a productivity system at your facility. And if you have some type of workforce system or productivity system, you have volume metrics. And volume metrics are the workload units or the indicators that we use to really map the volume or activity of a department. And there are a lot of different ways that we can map this volume. This provides us with a standardized way for volume capture. And keep in mind, this is not just important for your individual department or hospital. This is important for benchmarking and comparative purposes because you want to understand what you are collecting, what the definition is, and how it relates. And there are a lot of examples of areas where your definition may differ slightly from another hospital within your system or even from another hospital that you're comparing yourselves against. One example are nursing hours and nursing patient days. For example, your hospital might define a nursing patient day as the number of patients that are on your unit at midnight. This is often referred to as the midnight census. So if you're counting the number of patients that are on the unit at midnight, it's going to vary a lot from what someone else might be counting if they're actually counting the total care hours and dividing by 24 to get the patient days. Because when you look at the total care hours, you're going to include your outpatient care. You're going to include patients that may have been admitted on that unit at 1 a.m. or 2 a.m. And you're also going to include patients that may have been discharged very late in the day at 10 p.m. or 11 p.m. So typically, there's going to be a difference between calculating the nursing hours against the actual census at midnight. Another example, an area that you want to be really aware of, and this is just another area that we're seeing to become more and more important right now, are how you capture your clinic visits or your provider clinic visits. And this is extremely important as we start to transition our clinic visits to include more RN visits. We're starting to see a lot more activity. And had we had this conversation or LinkedIn Live 10 years ago, even though it wasn't a thing, there basically would have been a situation where our visits for RNs would have been less than 1% of the total clinic visits. Now, as RN visits are becoming more common, the RNs are participating a lot more in the care of the patients. We're starting to see this approach 10% or 15% in some areas. And in clinics that have a very high rate of RN visits, it could be as high as 30%. So making sure that you're capturing the volume is important, but also you want to be aware if your department is including those RN visits, because if you are comparing your organization to a hospital clinic that's only capturing the provider hours, which are your direct physician hours, you're going to be inappropriately benchmarking yourself if you're including the RN visits. You might look at that you're 130% efficient, or you're at best practice because you're including those RN visits when the comparative group definition is not. So it's extremely important for standardization that we understand the definition, that we transform our productivity definitions to match what's currently happening within the industry. The next area that might be extremely important to you are administrative workflows. There are differences in how hospitals allocate the resources in administrative positions. Some hospitals and healthcare systems have administrative cost centers, and they house all of their administrative positions within those cost centers, which means within their nursing units, there are not any quote unquote fixed positions or administrative positions. They're all flexible. This may be the same for laboratory, for radiology, for the operating room. And this is because all of those administrative or fixed positions are housed in a separate cost center. Now, if this is the case, and you're housing your administrative positions in your cost center, and you do not adjust for this in your benchmarks and in your productivity target, you're setting yourself up for failure because you're not taking into account the fixed component of your target, which on top of it's going to be variable based off of everything else that's happening. So being aware of the different types of allocation, being aware how they impact your benchmarks, and also how they benchmark your own individual performance. So understanding where your administrative cost centers actually housed, where are the FTs allocated, and how are you charging those? And then making determinations based off of that will provide you with a solid system for standardization. And if you work at a larger healthcare system, also keep in mind that many healthcare systems take a large portion of those administrative positions considered to be corporate cost centers, which means you might look at a critical access hospital or a very small short-term acute care hospital's benchmark and see that they only have half of a person in HR. Meanwhile, you're a standalone critical access hospital and trying to figure out, well, how on earth are they handling that with only part of a person or zero point 0.5 of a resource? It's because the other resources are at the corporate side. So again, understanding the standardization, understanding how it impacts you, and making adjustments for it is extremely important. The next opportunity includes position control and human resources processes. This involves, again, understanding how you're orienting all of your incoming employees and what the onboarding process is and making sure it's consistent and it's effective in all areas. You also want to have a systematic process for the job requisition approval and understanding how you post those positions. And one thing to keep in mind with this job requisition and posting process is you do not want to have positions that are posted for 18 months, for 2 years, for 3 years, for a few reasons. Number one, it provides the appearance that you're not able to recruit into those positions. And number two, do you actually need the same positions today that were approved 2 years ago? So you want to have a systematic standardization process for how you approve those positions, understanding if you approve them based off of your position control system, based off the budget, based off your productivity target, and how those decisions are made for variable departments and how they're made for fixed departments. Also, which individuals within your organization are responsible for the approval process? Do you do it through a productivity committee? Is it done through the senior leadership team? Do you have another sign-off process that might be involved through your human resources protocol? But making sure that you define it, communicate it, and then everyone's consistently following it. We also want to make sure that we're looking into variance reporting and accountability structures. You can't manage what you do not actually define and benchmark and report on, but you certainly cannot manage something if you're not holding people accountable to it. It is one thing to have a productivity report, to have a position control system, to have a budget system, and to have variance reports. But if you are not holding people accountable to those reports, they're going to be very ineffective. So you want to not only make sure you have the reports in place, that you have a position control system, that it's interacting with the finance budget, that you have a process in place for acquiring positions and actually posting those positions, but making sure that you're holding people accountable when they're varying from the budget, when they're varying from productivity, and when they're varying from position control. We also want to talk about the fact that within the productivity systems, we want to have a benchmark. And it's important to benchmark on two different levels. And standardizing this throughout all of your departments and your entire organization is important. You want to not only benchmark internally, which we know a lot of hospitals are doing, but you want to benchmark externally. Understanding how you have changed over the course of time is important for your internal processes. And let me just provide a note that we're never going back to 2019. So for your productivity targets, please do not set them at 2019. We're hearing that a lot because people say if we could just get back to 2019, everything would be great. You want to start fresh and start now and update all of those targets for what's currently happening. But you also want to take a look externally. So you're looking internally to see where your current status is, but make sure you understand externally, how do I compare against similar organizations? How do I compare against my peers? How do I compare against best practices? What are we doing that's the same? What are we doing that's different? And once you have that information, you can standardize processes that move the system forward. You also want to set targets that are achievable. A lot of times we have this reaction internally to set everything at best practice or everything at better performing or make sure all departments are at the 60th or the 65th percentile. And that makes sense because we want individuals to strive to be high performing and departments to achieve best practice and work towards those areas. But we want to think about mentality as well when you're an individual manager working towards a goal. If we set a goal that seems so far away, something that we're never ever going to attain, that no matter what we change, what FTEs we have, how we adjust our schedule, how many patients we get, that we're never going to get there, we're not going to try. So we want to make sure that we set systematic, realistic targets and turn the dial slowly over time to move the organization forward. This requires standardization of targets. And oftentimes this could be done through a decision rule. This could be done by looking at departments that are below the median and having a higher expectation than departments that are operating above the median. Regardless of what the process is, make sure it's standard for everyone. I encourage you to not make different roles for your clinical areas versus your administrative areas. Because when you set different rules and you set different areas of responsibility or set different targets and standards, you are now creating dissension and you are creating reasons for people to argue with the targets. We want to make sure that we have a systematic approach that's consistent. For example, if you make the decision that we're only going to flex our variable departments and our patient-facing areas, and we're not going to worry about flexing our administrative areas, we have now created different performance expectations for one group compared to the other. In the reverse, if we make the decision that we're going to leave all the clinical areas alone, our patients matter, we have to have the highest possible quality of care, so we want to not take anything away from those hours. And let me just reference the fact that there is a high correlation in quality and productivity. The more productive your hospital is, the more efficient you are, the more you pay attention to those processes and procedures and improve your workflows, the higher you often perform on quality and patient satisfaction. So productivity does impact all those areas. But we want to make sure that if we make that determination that we're not going to care about the productivity of those areas and only hold our functional areas, HR, IT, human resources, all of those areas to those benchmarks and standards, we again have created dissension, different expectations, reasons for people to not move forward because now it's not consistent. There's not a standardized, disciplined approach. So regardless of what you do at your hospital or healthcare organization, and there is no right or wrong, make sure the approach is standardized and make sure you're setting targets that drive accountability. And one of the ways that you can really help your organization advance and improve accountability and improve productivity is to start to allow your leaders, your senior leaders, your C-suite, even your middle managers to work with coaches. Coaches can help point out areas and blind spot that your team may not be seeing. They also bring best practices to the table, share outside resources and expectations, and continuously help you evolve, higher your level of performance, and simply level up on a day-to-day basis. By taking this approach, your entire team can systematically start to work on one or two areas that they can improve per month. And when you look at the organization 12 months from now, you're not even going to recognize it. And as you take the step-by-step approach and you improve your standards, you improve your policies, you improve what you're doing, you provide leadership development, allow your leaders to actually get the coaching to provide best practices, you now are in a totally different place. So I'd love to hear your perspectives on what areas you could standardize, what areas that you might be able to do, and please drop that in the comments. We'd love to hear from you on what you think in areas that maybe we missed that could have standardization within healthcare. We're going to pivot now to go to position evolution and talk about the administrative areas and productivity and support areas. Because one of the places that we're seeing a lot of attention right now is in the functional areas. There are requests to benchmark span of control. There are requests to benchmark the administrative areas, to do a deep dive into supply chain, a deep dive into information systems, a deep dive into the HR areas. All of these areas tend to be positions within the hospital that do not flex daily. This means they're not routinely held to productivity standard, possibly where they're going up and down based on the patient census. So how can we manage it? What can we do within our productivity, workforce management, workforce optimization system to heighten our attention in these areas and to provide some oversight so that we can manage them in a way that makes a lot more sense? This may include an expectation for flexing the staff, and how you flex that staff could depend on a lot of different things. For example, in finance, you may find that at particular points during the month, you have a higher need for resources because you're closing the budget. Maybe this happens on the 10th of the month. And if you're flexing your staff, maybe you make sure that during that 10th of the month or that budget close, you have more resources, but you consistently and consciously flex the staff at the early portion of the month or later in the month. There are also ways for you to use tools to scale the staff up or down based off of volumes in your department and volumes within the hospital. For example, All hospitals, healthcare organizations have some type of volume that's driving the need for the fixed positions. If you're in a traditional hospital, it's going to be discharges or patient days. If you're working in an outpatient center, it might be visits, operating room procedures, it might be something else. But regardless of where you're working, there is a volume that's related to the need for the fixed positions. And regardless of how many fixed positions you have, it does not matter. You are still only going to get paid the same amount. Let me break that down for you again. Regardless of what resources you place in finance, in HR, in IT, in all of those functional areas, your reimbursement stays the same. And for that reason, it's extremely important to make sure that we're managing those resources and allocating those resources effectively and efficiently. So as we're looking at this, we want to maintain flexibility throughout these areas, and we want to be able to flex them up and down. So one of the things that many of our clients will do is look at the discharges for the hospital and look at the patient days for the hospital. And they will determine bumpers or actually limits, upper and lower limits, and might really put in place what's considered a green, yellow, and red light system that tells you when these areas might need to flex up and down because the volume in the hospital is extremely low or extremely high. And right now, we need to take steps to make sure we're managing our resources more effectively. So if you're thinking about this bumper system, you place a range around your discharges, a range around your patient days, and you determine what those real low levels of census are. And when you hit the red light, when the census falls below that level, all of those areas are expected to flex in some way and take measures to make sure that they're appropriately allocating resources. In the same way, you could have areas that are in the yellow range and look at those areas and make those determinations. And then when things are green and the volume is flowing, everything systemically goes through that piece. We have a question on how departments that are using adjusted discharges and adjusted patient days can best use productivity benchmarks to plan their staffing. And this is a great question because a lot of departments use adjusted patient days and they use adjusted discharges. And if you're an administrative area, this might be the easiest metric for you to utilize to compare yourself against other organizations or other facilities. And at the very baseline, the first step is to find your comparative group, find those hospitals that you're like, and understand how many resources do they have in your area and your department. So step one is to understand how you can use those adjusted days and those adjusted patient days and discharges to see how am I comparing to other organizations. So if I have 15,000 adjusted discharges and I know these other hospitals average 15,000 adjusted discharges and I have 6 people in that area and the other hospitals are averaging 4, it starts to raise the question. What are they doing differently? What processes do they have? What technology are they utilizing? What are they doing with their scheduling and their system and their roles and responsibilities that I can learn from? What changes can I make systematically over time? So maybe I can go from working with 6 to working with 4. So that's the first step in planning your staffing. And the second step is you want to understand what roles they actually have. What makes up the position? What is their skill mix? What is their administrative structure? How are they cross-training? How are they utilizing these things? And this is where utilizing an outside reference or an outside resource becomes extremely important. Because sure, you could get on the phone and you could call 30 hospitals and reach out to everyone, and maybe you'll get through to someone. Maybe you'll be able to schedule 2 out of those 30 calls. Maybe you'll have a great, valuable conversation. Or you can reach out to someone and say, hey, what are you seeing in this area and what best practices are they having to benchmark and adjusted discharges and what can I do differently? And that person is going to tell you 2 or 3 things that are going to make a huge difference. And you just gained a lot of time because I'm pretty sure that you might not have time to sit on the phone and make those phone calls because there's a lot of things happening in hospitals and healthcare systems. So focusing on this is extremely important. When we're looking at the flexibility, keep in mind that a lot of times we think of silos. I work in human resources. I work in finance. I work in IT. I work in this area, and I cannot cross over and to support everything else. But we have to remember we're one team. We are one department. If you're a senior leader, if you're in the C-suite, if you're a middle manager, when you come to that senior leadership team meeting, when you come to the budget meeting, keep in mind you are wearing the healthcare system's hat, you are wearing the hospital's hat. We are not there to protect our individual area, our individual department, our individual function. We are there to serve the hospital. We are there to serve the community. We are there to serve the patients. And with that in mind, we have to keep track of how we want to influence things and how we want to approach our cross training and collaboration across departments. So the flexibility in administrative departments can come from you realizing that you have someone in finance that's only 70% allocated, and 30% of their time, they're not really busy or productive or doing anything meaningful. Yet HR has a need for additional tasks, but they don't have a need for a full position. In the historical past, we would say, well, that's my person, that's my FTE. It's going to hurt my productivity if I let them help you. Yet, again, we all work for the same healthcare system. We all work for the same hospital. We improve our efficiency by allowing that individual to support the other area that has a need when we do not need them the entire time. Now, yes, you should work through the allocation process and make sure those hours are floated to the appropriate cost center. But we want to break down silos. We want to cross train. We want to remove this. We want open communication, because it's when we have that open communication and that open collaboration that we can really make huge impacts overall on our efficiency and our productivity. So what types of volumes and metrics should we use to benchmark these? We had the previous question where we talked about adjusted discharges, adjusted patient days, and they are typically the most common utilized metric in administrative positions. However, we can also use additional fixed metrics or variable metrics. Now, the difference between a fixed metric and a variable metric is that a fixed metric tends to stay the same throughout the fiscal year or changes less often, where variable metric is going to consistently evolve and consistently change. Fixed metrics in these areas might be examples of marketing. We may benchmark it on the dollars in the marketing budget. This might include the dollars that we spend on social media advertising. This may include the dollars that we spend on the website. But we get the total marketing budget, and that provides us with a great way to actually benchmark that particular cost center. We can also look at gross revenue. And gross revenue would be a way to look at a finance department and allocate it to anything dealing with revenue and dealing it to anything dealing with those approaches. We might use budgeted FTEs. We might use total FTEs. So anything that's going to give us something that's fixed and stable is a way that we can actually allocate that. And we have another question coming in. And this question is, what's the best approach to allocating administration positions and grouping them in one cost center or spreading them out? And this is a great question, and there are a lot of different philosophies for this. I think the question and the answer are going to be determined on what's your end goal. If your end goal is to really to remove the noise or to remove some of the fluctuation that you might see within the cost center from those fixed departments, and to really understand how you need to flex your clinical staff up and down on the volume and to remove the noise of the administrative cost center or the administrative positions, then in that case, I would recommend that you keep the variable positions in that cost center and allocate the administrative positions elsewhere. However, you might have a situation where maybe you only have a 0.3 administrative position in the cost center or a 0.5 administrative position in the cost center, and maybe you don't have enough administrative positions to allocate into an administrative cost center. If this is the case, what you want to make sure you do within your productivity target is understand the total allocated functional resources that are fixed. This might be part of a manager, it could be part of a unit secretary, it could be an analyst, whatever that number is, that's your baseline. You're not starting at the 0-0 axis with that staff, you're starting above it. So your position now is that you're starting at 2.5 because you have 2 full-time fixed positions and a part-time. And from there, you can allocate up and down. So again, the answer to the question really devolves, what are your goals? And once you know the goals, you can decide whether it's better to house them in one cost center or to keep them in the actual cost center of the nursing area. Regardless, you want to make sure that you have a structure in place to understand them and to manage them. Now, when we're looking at variable metrics, we've talked a lot about the adjusted patient days, we've talked about the adjusted discharges, but variable metrics could also be end users in your IT department. It could be the number of purchase orders that are actually going through supply chain. It could be the number of calls in a call center. To think through this, whether it's better to have a fixed department metric or a variable department metric, I encourage you to really think through if the majority of the work in that area is dependent on areas that change or volume that changes, or is the work in that area really fixed and does not depend at all on volume? And I want you to think through that honestly. For example, human resources. HR activity is going to ebb and flow a lot based off of the number of your head count, based off the number of full-time equivalents, based off the activity of the individuals and the number of positions you're recruiting, the number of people that you have to provide support through your benefit structure. It is very much related to the positions and the people, and there's a high correlation between them. On the other hand, you might look at marketing. And in the marketing department, there's really no strong correlation that you can make between any volume of activity and the number of positions that you have in marketing. So maybe in that case, it should be based off the budget. So really take a deep dive and an introspective approach into how you're thinking about it and be honest. Is there a volume metric or variable factor that influences the department? If the answer is yes, it should be a variable metric. If the answer is no, it should be fixed. It could be square footage in environmental services. It could be square footage in areas that deal with facilities. So be honest about it and then take the approach. When you're managing fixed positions, you want to make sure that you're really looking at these areas based off of how you're going to allocate them and whether they're tied to the volume or not. So as we're thinking through those components, we want to also think through areas that might be more volume related, like registration clerk, like the call center, recruiters, analysts, and those might have some metrics. Now, keep in mind, you can set a productivity target for the department and have individual targets for the department employees. So for example, you may have a goal for your financial team that's different than what you're holding your registration clerks accountable to. So you might have a target overall for registration, but then when you look at the clerks, they're expected to register the emergency department patient within 8 minutes. Whatever those metrics are, they should be related, and you want to have a consistent approach towards it. If you're taking all of these steps and you standardize your workflow, you standardize what you're doing within your productivity system in the individual departments, as well as other areas, you can really move your process forward. But you don't want to lose sight of the management of the administrative positions and how we evolve those positions and our leadership surrounding those positions over time. Efficient resource allocation is extremely important right now. And organizations everywhere in healthcare are really looking at this because ultimately we have limited resources because we have limited revenue. And when we're focusing on that, we have an obligation to make sure that we're utilizing our resources efficiently. And when we're doing that, we want to look at the staffing levels. We want to make sure we're providing high quality, safe care, but then we want to make sure that we're doing it in an efficient process. Are we making sure that all of our clinical people can actually provide clinical support and that we're not asking them to get burdened by administrative tasks? Do we have processes in place to reduce redundancies, to reduce errors, to improve our effectiveness? So making sure that we have the proper productivity system, the proper position control, an efficient budget process, but also ensuring that all of these resources are allocated efficiently will help us minimize waste. And I don't know if you've seen any of the articles lately, but there is a lot of waste in healthcare. The last number I saw was north of $8 trillion. And that's a big number. And sure, it's not all something that we can impact. But if we start to chip away at it through standardization, resource allocation, productivity, and cost control, we can make a huge difference. So I really encourage you to look at your system, look at how you're managing these, and reach out if you have questions. Drop them in the comments if you're watching this on the replay. because as healthcare costs continue to rise, it's going to become even more significant for us to make sure that we're managing these effectively for our patients, for our healthcare systems, for our outcomes. Because controlling costs in all areas, the patient-facing areas, the administrative areas, the functional areas, it's going to really help us move the needle forward. So we have to pay attention to how we're billing the patients. We have to pay attention to how we're procuring our supplies. What are we doing in resources? Because focusing on everything will help us to make a difference at our individual levels. So keeping in mind the standardization, keep in mind what you're doing on a day-to-day basis and looking at these resource allocations of your management positions. And if you take these steps, you can have huge impacts across the board. So I encourage you to follow Altius on LinkedIn. Please be sure to follow our YouTube channel. You can find us on Instagram. You can find us on Facebook. And we're very accessible with comments and questions, and we'll respond pretty quickly. So if you found any value in today's conversation, you're looking for new approaches to your productivity system, to workforce management, resource allocation, or simply want to talk about what's happening in today's environment as we all work through the challenges of staffing shortages, we all work through the challenges of recruitment, retention, and improvement right now, reach out. We'd love to assist you. And thank you so much for joining our LinkedIn Live.